Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data, proudly brought to you by Pulse IT News. I'm your host, Louise Shaper, and this is our Pulse Summer Series, where we are revisiting some of our most timely and enduring conversations from the Pulse Pod archive. Now, in this episode, George and I are joined by Dr. Alain Labrique, Director of Digital Health and Innovation at the World Health Organization. Alain is one of the most influential global voices shaping how digital health is actually implemented at country and system level. Recorded in late 2024, this conversation takes us right inside the machinery of global digital health, how standards are set, how consensus is built across 194 countries, and why foundations like governance, interoperability, workforce capability, and trust matter far more than shiny tech. Alain is such a lovely man, and he shares with us his journey from infectious disease epidemiology and maternal health in Bangladesh to leading WHO's global digital health agenda. Alain offers rare insight into what really changed during the pandemic, why telehealth and digital public health reached an inflection point, and why countries simply can no longer afford to experiment in isolation. If you care about digital health at scale, specifically public health as well, not just pilots, but systems that last, this is a conversation well worth revisiting. So after this quick break will be our interview with Dr. Alain Labrique. Today, George and I are thrilled to have Dr. Alain Labrique join us in the Pulse Pod studio. Alain is the Director for the Department of Digital Health and Innovation at the World Health Organization, where he is based in Geneva. Alain is an infectious disease and population epidemiologist who has spearheaded groundbreaking research in maternal, neonatal and child health in resource-limited settings. He's won awards, published a heap, and he's well-known and distinguished figure in the realm of digital health and innovation. He's also a self-described digital health and standards geek. Alain, thanks so much for fitting us into your busy schedule. Welcome to the Pulse Pod studio.
Great to be here. Great to meet you and George. And I've heard so many wonderful things about this podcast. I'm glad to finally be on with you.
I'm glad we can make it happen.
Really looking forward to that global outlook.
So, Alain, I can hardly keep up with your LinkedIn updates. So which country are you in today? Where are you joining us from?
I'm actually in pre-winter Switzerland right now, finally at home after what seems like 4 weeks on the road, a number of global meetings where we've been discussing the future trajectory of digital transformation of health systems, from the UN General Assembly in New York to working with the Ministry of Health in Thailand. I just got back from the Global Health Exhibition in Riyadh, Saudi Arabia. So this space is sleepless and tireless and requires a boundless amount of energy, which, I'm glad to say I still have some of, but I'm glad to be working with an amazing team who makes it possible around the world.
So what's your trick? When you wake up in the morning, how do you remember where you are?
I don't. I literally have to pinch myself and say, no, which country am I in today? If my wife is there next to me, then I remember that I'm finally home. But the career of global health is one that keeps you on the road. And so it's been a good 25 years of constant travel, because you can't sit behind a desk and help craft the future of global health. You have to be out there in the field, talking to policymakers, talking to people, talking to implementers, and really trying to understand what are the pain points, what are the challenges, and what can you do in the position that you are to help drive things forward. And I think a lot of it is just the privilege of having literally sometimes a bird's eye view on things, where as you travel around and speak to many different people, there's a lot of unique challenges that people are facing based on context, on resourcing, on the politics. But there are also a lot of fundamental similarities. And I think it's those similarities that we're looking to strengthen the resourcing for, and making sure that in 2024, going forward, no country should have to start from scratch. There's so much out there in terms of lessons learned, in terms of best practices, and in terms of technical building blocks. So what can we do as a norms and standards agency, as a convener of multi-stakeholder dialogue here at WHO? What can we do to help bridge some of those knowledge and practice gaps that keep people from making substantial progress. And so it's really exciting. It's a challenge, but we wouldn't do it if it wasn't a barrel of monkeys, as they say. It's a constant fun.
It's obviously a very global role because this is why you're just your travel itinerary. But WHO appointing a lead for digital health, I mean, especially having a global mandate is a really big deal. You've been there for just over 2 years. Tell us, how did you land yourself in such an esteemed role? And what was your career journey like leading up to that? I mean, I'm sure you didn't finish med school thinking I'm going to be traveling around the world managing digital global health.
I actually started life as a molecular biologist. I was studying how yeast cells divide as a way to understand the granular processes for DNA replication. And I got really tired of staring down the barrel end of a microscope. And from there, I went on to study epidemiology and learn about infectious diseases. The thing that really, as someone who was born and raised in Bangladesh, a country that is such an amazing place with such beautiful landscapes and even more beautiful people, the tragedy of maternal and neonatal mortality was something that had been gnawing at me for decades, since my childhood. And the opportunity to study how we could potentially prevent mothers and newborns from dying, I think that really took a lot of my mental energy. And so that's what brought me into public health, right? To try and study at a macroscopic scale what were policies and interventions and programs that could be scaled up to improve the lives of folks on the ground. And as I was working in rural Bangladesh on my doctoral thesis and then as a young assistant professor, we began to see the mobile phone revolution happening. We began to see this leapfrogging of the copper cables that other countries had to install before they were able to speak over long distances. And I remember vividly in the early 2000s, I was running a huge project in northern Bangladesh, and we were just about to put out a tender for carrier pigeons.
Wow.
Because we were so frustrated at not being able to communicate between two of our field sites that were 50 kilometers apart. So I had bought possibly every type of wireless communication device on the market. And, we were still sending messages by courier. And the courier had to jump on a bus, travel 50 kilometers, get the response to that message, come back. And I was thinking, surely we can find something that works better than this. And carrier pigeons was going to be the next option.
They would be faster.
Definitely faster and potentially more reliable.
Good for the environment.
But then we realized, the mobile phone was rapidly making inroads, right? Leveraging fiber optic networks that had been laid in the 1970s. But almost overnight, we went from a country where very few people had the privilege of being connected to now mobile networks covering the entire country of Bangladesh, and the cost and coverage and ownership of devices changing rapidly. And so, that was the sort of harbinger of a future that working out there, reading maternal verbal autopsies and watching how a simple phone call could change the trajectory of a pregnant woman from near death to survival was so powerful. That was the inflection point for me where I said, there's something here. We need to study it. We need to understand better the context and ecosystem of how we go from the serendipity of having a phone in the right place at the right time to seeing how can we build national programs that leverage connectivity, that leverage information communication technologies, that leverage clinical informatics all together in this burgeoning field that you and we have all been a part of called digital health. I returned to Johns Hopkins where we launched a new center for digital health that working closely with WHO and many others in the space, we began to really try to define the parameters of how do we talk about this multidisciplinary space. There's informatics, there's computer science, there's communications, there's public health, and getting all these different cultures and languages into a room to get them to agree on things was a huge hurdle, but we made it. We helped to develop the first ever guidelines for digital health. And then before we knew it, WHO was going through a transformation, and DG Tedros' team decided that it was important for WHO to have a department of digital health. And so when I got the call that they were looking for a director, I thought to myself, there's a lot we can do here at Johns Hopkins, but there's a lot we can do here at WHO. there's a lot of other exciting stuff that can be done from a global level. And it's not just here in WHO HQ, it's across the 6 regions. There are digital health focal points that are amazing people who have done great things in their life journeys. And all of us together working as a really global team with many people who have had similar trajectories from public health, infectious disease, information technology, coming together under this banner of digital health makes for a really powerful group of people to think about how to do this and leverage these tools to change lives.
Yeah, absolutely. So, given what you just said, it's not just you at this global mandate. You're responsible for a team of people who report to you, but then you work with how many countries, how many global field offices. It's a really big role. For those of us who haven't had the pleasure of that sort of mandate, what does your week look like? Is there an average week, like when you're not traveling or when you are traveling? What does it look like? And how would you define the purpose of your role?
20 years ago, one of my mentors told me that the first few years are really tough and you feel super busy, but then things calm down and become normal. And I'm still waiting for that because I think no 2 weeks are exactly alike. I like to say we have 194 bosses. So as a member state organization, so WHO is the apex agency within the United Nations system for health. So this UN agency, the World Health Organization, is responsible to serve the 194 member states that give us our mandate to help provide the norms and standards, that is the science-based guidance to countries on what are best practices, what are the technical standards, what does the scientific research evidence suggest are the best investments for governments to make in order to drive benefits in terms of universal health coverage, in terms of reductions in disease and death, and in terms of better health outcomes and wellness for people everywhere. And so, our mandate is really one to serve the entire globe, not one region, but we are what we call a 3-level organization. So we have 6 regional offices representing each of the major population continents around the world. We have about 160 country offices that are led by a WHO representative in that country, and then the teams of people who support those offices and work closely with the ministries of health and other ministries to execute the translation of the science-based guidance into practice, right? So it's not just about us sitting back and reviewing science and putting out these big books of guidance, but it's also about how do we move best practices and guidelines into policy and into programs that ministries are running to improve outcomes. And so I think for us, the average week involves technical work. It involves bringing together experts because we may have expertise, but we recognize that expertise is evolving and we need to always be sure we are convening the right people who are from all of these regions who are working on these problems on the ground and making sure we're sourcing the current state of science and state of best practice from those people. And then, we have a lot of meetings where we have to build consensus. Just to note, there's often a criticism of the United Nations or even WHO in terms of the pace at which we sometimes move. And I think that's a fair criticism because, some of these processes are slower than if we were in the corporate environment or maybe in an NGO. But it's because we have to build consensus. It's because we have to bring others along, right? So I think there are many proverbs that abound around, if you want to go fast, go alone. If you want to go far, go together. And I think by building this consensus, by making sure that we're bringing along all the different perspectives and making sure that people are truly on board with the changes that we are discussing, we actually achieve in the long run much more transformative change than short, cheap, activities that really aren't sustainable over time.
Yeah, it's the only way to get things done. I couldn't imagine trying to build a consensus with such a big mandate, but also such a large stakeholder community. So the fact that you've actually produced a huge amount in your 2 years, Alain, which I'm very familiar of, and we'll get into some of them soon, but it's hats off to you and your entire team. Like, it's a massive, big undertaking and you've achieved a lot.
So it is very impressive considering also the scope that you're going from, first, second, third world countries with resources, without resources, and balancing that global resource challenge as well, because we have a challenge here in Australia where we are pulling resources from countries who probably need them more than we do just because of the way the national economies work.
It's flattening quite a bit because I was just in a meeting in Berlin a few weeks ago where on the same stage, we had the chief information officer of Australia, the chief information officer of the UK, the chief information officer of Brazil and India. And it was quite impressive to see the commonalities in terms of the standards, in terms of the architecture, in terms of the governance that were shared across these very different geographies and political and economic realities. Then there were differences. And, I think there's a great convergence happening now around the world, which we're moving away from an era of what I will call digital experimentation. So where people have been building confidence in the potential of digital as they've seen how digital has transformed other sectors completely. And I don't use this word transformed very lightly because you look at the financial sector and you see how banking in 2024, anywhere you go in the world, is now fundamentally different from the way it was a decade ago. And that is attributable very, very largely to the digital revolution that has happened around us. And I think these kind of changes require a period of careful experimentation, of cautious, poking the animal to make sure it doesn't bite and make sure that, we have a robust plan of how we need to move forward. But I think the pandemic was a big wake-up call. The countries that had previously invested in governance, architecture, and ethical and policy frameworks were the ones who were able to pivot very rapidly, leverage a robust local ecosystem of entrepreneurs and developers because there were standards, there were interoperability backbones in place. They were able to pivot systems and move them to be responsive to the pandemic, whereas countries where those systems didn't exist, where people's trust hadn't been built in those systems, where there were still doubts in the public's mind around confidentiality and data protection and data sharing, that led to a lot of hesitancy and a lot of doubt around whether these systems were truly trustworthy and whether they would achieve the objectives in mind. And so, I think that's sort of the big wake-up call to countries to say, well, if we want to really benefit from the digital revolution in health, we have to start building foundations. The convergence of epiphany and, my taking on this role with sort of the global teams converging around this sort of philosophical approach has really been a fantastic opportunity to move forward in a big way.
On that point, because the Australian Health Minister during the pandemic was quoted as saying that we managed to do 10 years worth of reform in 10 days as a result of the pandemic. So that ability to do that digital transformation was obviously built very much on the backbone that we'd put in a national network, we'd put in a national shared record, we had done a lot of those sort of things.
George, look at something like telemedicine, right? I mean, that's a great example where telemedicine is not new by any standards. It's been around for more than 50 years, and we have accounts and data going back to when people were doing consultations with clinicians by ham radio in the outback of Australia. And, I think as we look on the global policy landscape, there were many countries where telemedicine was obstructed, not because it wasn't shown to be effective or that there wasn't a strong argument for extending services to people where and when they needed those services, but it was more policy barriers that were in place for a slew of reasons that was preventing telemedicine from being used, whether it was policies around reimbursements, policies around safety and verification of credentials, et cetera. But these are things that are relatively solvable if we want to. And so the Pandora's box was really opened in a good way during the pandemic, where people got to experience the benefits of telemedicine, right? The parents worried about their kids at 3 o'clock in the morning having access to a clinician or a nurse using their phones. And I think it's going to be hard to put that genie back in the bottle now that people have had a taste of the convenience and access to health information that telemedicine affords.
I agree. And I know that in a recent speech, you commented about this digital inflection point. So, I mean, whilst the pandemic drove a lot of change, I guess the challenge we now face is in sustaining that rate of change. What's your experience been like around the world and people maintaining that rate of change that we saw in the pandemic?
It's quite phenomenal. I think as we look around the world, we see things like, in India right now, there's a national telemedicine platform that receives between 350 to 500,000 calls a day.
Wow.
Just think about that for a moment, right? And the studies that are emerging now around just that level of functionality reveal that this is not only a health intervention, it's potentially a climate intervention. Because for each of those calls, on average, you're reducing the carbon footprint of a person by about 20 to 25 kilometers, right? That they would otherwise have had to travel to get to a facility to meet with that provider. And so you multiply 20 kilometers by 500,000, that's an awful lot of carbon that we've eliminated from the atmosphere, making telemedicine not just a health intervention, but a climate intervention. But, in places like Rwanda, we have citizens are connected through a universal health platform. In Zanzibar, every single community health worker is now equipped with a piece of technology that allows them to register their clients in a continuous health record. And now you think about that for a minute. A continuous health record, something that many people in the West take for granted as a fundamental given, right? When you go to see your pediatrician, clinician, or specialist doctor, they're able to look at your entire history, usually, and get a sense of where you've been through your health journey. In many parts of the world today, that's such a privilege because you're going to see a doctor and it's as if that's the first doctor you've ever seen. And they have no idea who you are, what you've been through, what your allergies are, what your medical history is. And that's just not okay. So we're really hoping that with some of the work that we are spearheading and we're seeing countries really move forward with, that's going to change fundamentally in the coming years.
Fantastic.
Amazing. Now, one of the things I thought would give you the opportunity, Alain, to spruik some of the great work, the specific stuff that you guys are doing and the Pulse Pod can help promote. So one of the things that I know you guys have been heavily involved in is supporting that capacity building, the foundational work. So what are some of those capacity building initiatives that you're currently focused on? And, what are they doing to help countries accelerate digital health?
When we talk about foundations, human capacity is the first layer of the foundation. Now, we say we can't build skyscrapers without robust foundation. The foundation almost has to be as big and as strong as the height of the skyscraper. And similarly, it's that human capacity that we have to start with and making sure that something you've been involved with, Louise, right? The competency framework is just thinking through what are the basic digital competencies that a health worker in 2024 should have that they may not have needed 10 years ago. And this means it's not just a health challenge, it has to be in the education system as well, starting with elementary school, middle school, high school, university. What are the digital hygiene skills? We teach children to wash their hands, but we need to teach children how to change their passwords, right? To work in an environment that is fundamentally digital. What does it mean to be the custodian of your health record? What does it mean to do basic troubleshooting on technology-based systems? And so I think there's a whole host of digital competencies and competencies to be in a digital environment that need to be applied both pre-service, so before public health or clinical work, but also in service. As technologies are constantly changing, people's skills need to be kept updated. So almost like a CME, continued medical education, we need continued digital education as technology evolves. How do you function with this emerging space of generative AI? And what does a frontline health worker in Kenya need to know about this space. So that's one set of work. We also have been working on a series of trainings for policymakers. We have this thing called the Digital Health Planning National Systems course that has been a collaboration with a number of other partners that has reached now many, many hundreds of policymakers around. I think we just hit our 1,000th policymaker who has been through that curriculum, really training them in not just the shiny objects, but what happens in the background. What's the plumbing and the highway systems that have to be in place for the shiny cars and for whatever runs through the plumbing, the water, the clean water that people benefit from. And so I think we're really excited about training people, providers, policymakers on these foundations. The other thing that we're really, really, really excited about is local production. I'll be a bit provocative here and, say that many have criticized this space for being a form of neocolonialism, the digital colonialism where we have technologies and solutions being imported from the global north and west to the global south. And I think in 2024, we need to push back and we need to understand that capacity has grown tremendously around the world in all hemispheres. And we need to really be equipping local ecosystems, entrepreneurs, governments, and their partners with the tools and the building blocks that they need to start building solutions that are high quality, that are interoperable in country, in Kenya, in Bangladesh, in Chile, right? So that they have systems that are owned and operated locally and that can be expanded, extended as needed based on whatever public health and health priorities that country might have. And so over the last 2 years, we've done these mega workshops in Kigali and Cape Town, and we're just about to do one in December in Nairobi, where we're bringing to the table dozens of countries, the ministries of health and their technical partners who are coming together to learn how to use these building blocks, these standards-based building blocks, whether these are pieces of technology that are reference applications, so-called white labeled products that they can use to start from, or something that WHO is creating with a lot of partners known as the SMART guidelines, which takes WHO technical content, whether these are the decision support flows for HIV treatment or for antenatal care, and making them available to programmers in a digital technology absorbable format. So rather than having a programmer in a country spending hours and hours going through these giant books and trying to extrapolate what the decision logic should be in programming language, they can actually just go into the WHO SMART Guidelines library and ingest those decision logic algorithms into the software that they're developing, allowing them to focus more on the user experience and the design of the system as opposed to the semantic and syntactic structure of the software. We're really excited about, we're working with companies at Google, for example, offered thousands of hours of time over the last 2 years to help develop programming environment for the Android system, which Google is the custodian of, known as Open Health Stack. And that's allowed local entrepreneurs to build standards-based solutions in a much shorter amount of time using this development environment than if they had to build it from scratch. And so we're now able to have interoperability baked into the DNA of tools across the world driven by local entrepreneurs. So that's really, really exciting in terms of building capacity and empowering people around the world.
Absolutely. But can I also just give a shout out to your leadership and people like Graham Grieve and others? If there wasn't an informatician leading this, I'm not sure whether interoperability would be realised to be the important factor that it is. So, to be able to get the tech people, the big companies involved, the policy people all working around a standards agenda, good on you, informaticians.
He's one of our heroes around here, with the work that he and others have done on FHIR. It's truly been a game changer. As much as HTML was for the internet, FHIR has been transformative across income settings. FHIR is a standard that's being used now across the North American hospital systems And we saw Africa CDC last year come out with a continental recommendation for all systems to be FHIR compliant for national and transnational interoperability. So it's really exciting.
That has been. I mean, for Australia in particular, watching one of our success stories go global is great. The other thing, of course, is empowering consumers and making sure they're part of this journey. So it's not just a clinician or a bureaucracy-led initiative. And I know you have things like the Global Digital Health Certification Network. How does that work to enable both cross-border health sharing, but also consumer engagement in the projects?
Thanks, George. I think that's really exciting to talk about because if there's 2 3-letter words that I would like folks to take away from this conversation, the first is DPI, digital public infrastructure. And that's the sort of foundations on which successful digital ecosystems are built, right? Not digital systems, but digital ecosystems. Because if we truly want to have a person-centered digital transformation, we have to be thinking about what is convenient to the person. As individuals, as we go through our health journeys, we should have the ability to access our health record. We should have the ability to move from one provider to another as we experience different things in life, an accident one week and a diagnosis of a chronic disease another week, hopefully not week after week, but, in our lifetimes. And it would be nice for that information to be portable from provider to provider. And the DPI, the digital public infrastructure, whether it's digital identity, the ability to make digital payments, or even the backbone registries, the persistent health records, the provider registries that keep all this information updated as part of digital commons that benefits everyone is really critical. Because we realize that, if we're going to approach this in a piecemeal, vertical way, everyone ends up wasting a lot of resources building these pieces that should be built once and used multiple times. Each of the developers ends up building those pieces over and over again. Imagine if every car manufacturer had to build their own highway, or every train manufacturer had to build their own railway tracks, right? We're living in a nightmarish world. That's just not how infrastructure works. So the first word would be digital public infrastructure. And that will bring me to the question that you just asked, George, about the Global Digital Certification Network. But the second word that I'd like folks to remember is PHR, personal health records. Because combining DPI and PHR is the magic formula. And that's what the Global Digital Certification Network has done. Coming out of the pandemic, we realized that building a plane while flying it is certainly not the optimal way of getting from A to B. And so there's certain sort of precursor infrastructure that, if it exists, can unlock and enable people to have access to and be the custodians of their own health records, the information about their health that really should be a right for you to have and access when and where you need that information. And so during the pandemic, many of listeners will remember, if you happen to be in a place, your country had made bilateral agreements or multilateral agreements with other countries to agree to use certain standards to present a QR code when you were traveling from one country to the other to certify that you had received a vaccine or you had received a negative test to demonstrate your COVID status. Well, we realized that the inefficiencies of countries having to scramble to establish those partnerships during a crisis was no way to have resilient global health systems. And so in 2023, WHO took on the responsibility, based on the mandate from member states, to help create resilient global architecture that can empower people to be the custodians of their own health record. And so we stood up the Global Digital Health Certification Network, which today has over 80 countries as participants, that effectively covers nearly 2 billion human beings who now can have access to their health record and carry that record with them to share with whichever providers they see fit as needed, as for medical tourism, for religious pilgrimages, for whatever purpose. We've even had large countries come to us and ask, while we're working on improving interoperability between hospitals, can our patients be empowered by a personal health record that is verifiable using the WHO network so that they can port their information from one side of the country to the other side of the country? So, it's been a fascinating experience to see the enthusiasm for this fundamental infrastructure. I'll give you a most exciting thing and why I was in Riyadh last week. Last year, WHO, working with the Kingdom of Saudi Arabia, with Oman, Indonesia, and Malaysia, launched on top of the certification network, the Hajj health card. And in 2024, those countries were able to issue to their citizens almost 250,000 personal health records. So that these pilgrims, so every year, 3 million some pilgrims make this lifetime journey to Mecca and Medina for this apex religious pilgrimage of their lifetimes. And for many people, they've waited their entire life to undertake this journey. So they're usually elderly people. They're people who have a lot of underlying conditions. And the challenge that we heard from physicians in Saudi Arabia was, we get a patient coming in and we have no idea, is this person someone with a heart condition? Does this person have diabetes? Why are they coming in for urgent care? And the course of treatment would be radically different if we had some fundamental information about that person. And so using a new global standard known as the International Patient Summary, based on a FHIR environment, but we were able to work with these 4 countries to demonstrate that WHO certification network could serve as a way to verify the authenticity of that document. So WHO doesn't touch the data or store the data. We just say that this record that you're scanning was actually issued by a certified authority that the government has designated as an authority to issue a health record.
Yep. So you can trust it.
You can trust it because it's a verifiable credential. And so, like your passport, when you show up at a border, when they scan your passport, they know that this passport was issued by a government authority who has given the authority to issue passports. What this allows people to do now is to verify the authenticity of that record and to make sure that it is accurate information on which they can now base a healthcare decision. And so that's been really exciting to see. And we've had just this year as well, our colleagues in PAHO in the Pan American region announced the Pan American Information Highway, where they will be able to, across all of the South American countries, they're aiming to by 2030, to be able to transact this international patient summary across all of the South American countries as people move from Bolivia to Chile to Argentina to Brazil with that health record that they can be the custodians of. So to me, that is one of the most exciting things that we've been able to do. And as more and more countries come on board to this trust network, what we're doing is we're serving as a very sophisticated phone book. As the anchor of trusted information, we receive from all our 194 countries who is the authorized issuer of one type of certificate or another type of certificate. And then we just push that back out to whoever is creating the systems to read those QR codes to be able to verify, well, this QR code checks out with the trusted authority of Japan or Malaysia or Brazil, and therefore we can use this information with confidence.
That seems so impressive, Alain. And can I ask you to comment? I'm just thinking so many of our listeners will be listening to that and going, wow, that's amazing. I live in a more resourced country than some of the ones you've listed, and I don't have that. There's no international patient summary record. No one's giving me a healthcare passport, as you said. What do you think is the key difference in how the countries that you spend more time with, the ones that are being involved in these initiatives, what would you say are the key differences between them and other more resourced heavy parts of the world that actually still haven't managed to implement this type of really critical infrastructure?
I think we're seeing this change very quickly, Louise. I think across Europe, for example, many countries are looking at making a digital wallet available to their citizens. And a digital wallet is more than just your health record. It's really about having access to your land ownership history, your children's schooling information, your tax history. And so all of these things combined in a digital wallet where you can have access to a lot of e-government services in one place. But many, even high income countries, are passing laws that require health providers to give you access to your health information.
Yes, we're a fan.
As Australia has this digital front door, these movements towards saying, how can we ask people to be active participants in their health if we don't give them ready access to their own health information, right? And so, as someone who in their lifetime, I've had to have a health provider fax, and this was just in the last 5 years, fax my child's health records to the new provider because they didn't trust any other mechanism of transferring that information.
Yeah.
Gosh, this is really pivot point in making that information available. And, I do want to take a moment here because I think it's important as we're talking about all this exciting progress, we still have 2.6 billion people on the planet who are disconnected, who still don't have access to fundamental connectivity, let alone a lot of these sophisticated systems that we're talking about. There's substantial swaths of the world where electricity is still a challenge to get to. And so I do want to just make sure that I give a moment to address the digital divide. And that's something that, we're working very closely with the Broadband Commission through other mechanisms, working with the private sector and the network operators to continuously push the envelope on how we get more people connected. Because, as famously the advisor to the South African Ministry of Health said about a decade ago when we were looking at text messaging programs for pregnant women, he said, access to information is not a privilege. It's a human right. And I think that's really what should be driving us as we think about basic connectivity, because I've seen for myself how a phone call can change the trajectory of whether someone lives or dies. In 2024, moving forward, we should really be addressing these challenges of how we make connectivity universal. But I think you're right, Louise. There are countries where still today you don't have a digital wallet. And I think in the next 5 years, we'll see these things change. And one of the things that I think you can drive is public demand, because when citizens are asking for this, then governments are more likely to respond. And so I think this podcast and other efforts that you do in terms of creating advocacy among civil society, it's really critical that people are voicing, and youth have a big role to play in this. We work very closely with the WHO Youth Council and other sort of youth movements in health, where they are the ones driving and demanding that these things be available to them as they move into the future.
I'd love to segue into your FIDES program. Am I pronouncing that right? Is it FIDES?
Yeah, FIDES, like bona fides, right?
FIDES, okay. My understanding of that program is about actually empowering and utilizing healthcare influencers on social media as a way of combating misinformation. How does that program work and who came up with that? Because that seems pretty smart.
Yeah, it's a good segue because when we think about that second word I said, PHR, right? Personal health records and how you go through your own health journey, a lot of that has to do with the information that you have access to. And boy, if we didn't live through one pandemic, but two, the second one was an infodemic, as WHO termed it, really a proliferation of false or harmful information that was created with malintent. And so now we're seeing a new term being used, which is not just disinformation or misinformation, but malinformation. Information is created to sow political divisiveness, to sow mistrust in institutions, in science. And this has been a huge concern. And not just during the pandemic, but even before, a lot of difficulties have been experienced to get children vaccinated from preventable childhood illnesses in countries around the world where misleading information has been spread. And that's led to the resurgence of diseases that were eliminated for decades, coming back in high income contexts like the US and parts of Europe. And so this is a real challenge for us. And we recognize that WHO and wonky talking heads don't appeal to everyone. So for us, the importance has been, how do we get trusted information to people where and when they need that information? And so we've actually worked with all kinds of exciting companies and groups who are really at that frontier, whether we're talking about working with big tech companies through our tech task force to present this challenge to them and say, how can you, as curators of search engines, as developers of AI bots, how can you elevate trustworthy information from WHO and make that available to your users? And so several search engine companies and groups like Facebook during the pandemic highlighted WHO trustworthy content as part of the first information that people would see to help make sure they had access to that science-based content. So Fides, as you may know, is the Roman goddess of trust and faithfulness and good faith. So bona fides, that's where that comes from. And so the idea was we have this explosion of influencers, right? People who have millions of followers around the globe who are doing not just the latest dance craze, but they're also doing health content. Clinicians, nurses, midwives who are out there on social media promoting health content. So we said, why don't we team up with them, provide them with content that we feel is important to get out there, whether it's Mpox or flu or whatever priority the WHO is finding from countries that needs to be amplified, and ask those creators to use their capacity to message effectively to amplify that information. And so we have over 1,000 creators around the globe who we help to link up to the various platforms. We just worked closely with TikTok on a global mental health campaign to try and use the TikTok platform that has almost 1 billion followers around the world to reach different segments of the population globally with information that's in a format that they're absorbing and accessing. And so it's an exciting program. It's in its infancy, but if there are social media influencers out there listening to your podcast who say like, hey, I want to be part of that, reach out to the WHO Fides program. And, we'd love to see how you can help us move that forward.
It is exciting to see social networks being used for good rather than some of the purposes they're currently being used for. And just for your reference, the Greek goddess of trust is called Pistis. So you can keep that in mind for your next one.
I don't know, that might go over as well, but maybe.
Look, that's been a fantastic discussion. And, obviously digital health innovation is key. But the one buzzword that you've probably heard 1,000 times this year when you've gone to any health technology conference is AI. So where does AI fit into your big picture? Does it obviously enables us to do things that we've never been able to do before, but then we have the risk of what it can provide, and access to AI also requires access to some high-end technology. And we've seen some discussions recently about the global warming aspects of these large AI server farms. Where do you see AI going from a WHO perspective and from a global perspective?
So George, we could spend another hour on AI. So I'll be very brief. I'll say that WHO is cautiously optimistic about AI. We've been working in the space of AI now for almost 5-6 years. WHO already has guidance on using AI for diagnostic imaging for TB. And I think it's important to differentiate that AI has been a tool in the digital arsenal for quite some time, but that's been what we call probabilistic AI. So AI that's more in the space of machine learning, pattern recognition, model training, and then using those sophisticated computational models to perform repeated clinical tasks. This last 2 years has been characterized by the rapid rise of generative AI that is more human-like in its decision-making, but also more unpredictable. There have been a lot of challenges as people have scrutinized these systems with understanding hallucinations, understanding the representation of incorrect information with a level of confidence that might be associated with a very junior first-year medical student answering a question, but getting it blatantly wrong. So I will say that we see a lot of ways in which AI can accelerate routine administrative functions, summarizing information, putting together minutes or synthesizing large amounts of complex information, or even simplifying clinical messaging for the digestion of a general public or specific audiences. But we are not yet in a place where humans can be taken out of the loop. Even in those simple functions, right? Summarizing information or rewording things to be simpler, you sometimes get things wrong. And in the space of health, we have to have a very high bar of scrutiny, a very high bar of quality. And most importantly, if we go back to the Hippocratic oath of do no harm, we have to make sure that these systems do no harm as they are coming out of the gate, but as they continue to develop and become more sophisticated, that they continue to perform at the levels that we expect them to. So I think there's a lot of hype. There's a lot of enthusiasm around this space because of what we've been astonished to see AI do. But I think there's not a level of scrutiny that needs to happen before these systems are put into practice. And that's where, we have a duty to member states to ensure that technologies that are put into use are safe, effective, and cost effective. And so to your last point about the carbon footprint and the energy requirements of these systems, we're working with a number of academic institutions to explore smaller models that may be more efficient environmentally, but also perform very well in terms of accessing a known set of information and providing recommendations or feedback to people based on that well-boundaried set of information. Right now, you might find interesting, we have a digital information navigator that has been released called Sarah. That is an AI avatar that's available online that is plugged into a language model and that helps people find information around smoking cessation and improving healthier lifestyles that we've worked really hard to boundary to only access certain corpuses of information and to reduce the risk of hallucination. But it's not a perfect system, and we're using it as a way to learn how these systems could eventually be used to deliver information to people.
Excellent. I think it's a great way to wrap up our discussion, is that obviously innovation requires us to experiment, and experimentation also requires us to take some risks as we go forward.
I think on behalf of all the Pulse Potties, they would have learnt a lot. And I'm sure they've all been Googling while they've been listening to look for more information about all the programs that you discussed today. So thank you so much for your time.
Delighted to be with you. And maybe AI can help you to find anything that I've said that makes sense and weed out the things that put people to sleep. Worst case scenario, guys, if you're listening and your kids are having trouble sleeping, just put this on in the background, and my low voice does wonders when I have babies in my arms. Nothing like a digital health lecture to put the 2-year-old to sleep.
It may even incite some young people to get involved in public health, because one of the challenges we face here in Australia is getting even clinicians to get involved in public health. So it's been a really exciting discussion. So thank you very much again for your time, Alain.
Absolutely. Well, thank you all, and look forward to the next time.
Great.
Thanks. So that was our conversation with Dr. Alain Labrique from the World Health Organization. I've had the fortune of running into Alain at events every now and again, and he's always very generous with his insights and his time, and he loves to geek out with you as well. So if you run into Alain and ask him about tech, he will gladly geek out and show you what he's been experimenting with himself on his phone. But whenever I see Alain, what stands out to me every time, and re-listening to this interview has just cemented it for me, is just how grounded he is, not in hype, but in hard-earned lessons. And Alain really reminds us that digital health isn't about moving fast for its own sake, as anybody in digital health for longer than 5 seconds knows, but it's about building foundations which are strong enough to serve an entire community, indeed an entire global population. And as countries grapple with AI, interoperability, workforce shortages, climate pressures, etc., this conversation, I think, is a really powerful reminder that progress happens when we go together and we move together to shift that dial across sectors, disciplines, and borders. So thanks, Pulse Potties. Thanks for tuning in. This will be the final episode in our Pulse Summer series. In the next episode, George and I will be back with our regularly scheduled programming, where one week we bring to you a Hot Topics episode, and the next episode is our Amplify series, where we have some fabulous people on the show that we can learn from and be inspired by. So in the meantime, I hope you've had a wonderful January, and we will speak with you soon. Thanks for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions, and thanks to Emily Mara at Pulse IT for all her support. Big thanks to everyone for listening. If you haven't yet, and if you've got one thing that you can do for us in 2026, well, recommend us to a friend. That'd be great, and a colleague. But also, please make sure you subscribe. Press that plus button on the top right and subscribe, follow the show. If you have time to rate us, that really helps the AI algorithms find us and recommend us to others. And visit pulseit.news to catch up on the news from Australia, New Zealand and Ireland. Send any feedback or topic suggestions to pulsepod@pulseit.news. We always love to hear from you. Speak soon.